All right, I know more folks are going to join, but we'll get started right on time here. Welcome everyone to Project ECHO-Geriatrics and Happy New Year. I haven't seen many of you since our new year started, so I hope 2024 is starting off well for all of you. Thanks for joining. We will run the session like we usually do. We'll start off with a short didactic, and our speaker will have to run off to clinic. Right after the didactic, there might be time for just a couple questions, but they'll have to exit after the didactic, and then we'll get into our case presentation. And Dr. Pollard from Trios residency program is going to be presenting a great case today. So our speaker today is Dr. Michael Rosenbloom, who is a behavioral neurologist. He is a recent addition to the Memory Brain Wellness Center at UW, but has many years of experience in the clinical care of folks with Alzheimer's disease and dementias, but also a lot of research experience in this area, and is the director of clinical trials at the UW Alzheimer's Disease Research Center. And he's going to talk about a hot topic, which is lecanemab. So I'll let you take over. Thank you so much for taking time out of your busy day to talk to us, Dr. Rosenbloom.
Yeah, thanks, Kate. And I appreciate the kind introduction. And also, I'm really honored to be able to speak to all of you today. I've been leading the lecanemab effort here at University of Washington, and we dosed our first patient on December 1st. And I have to tell you, from my perspective, the patients and the referrals are coming out of the woodwork. So it's really changing how we approach patients with at least early stage Alzheimer's disease. And I just wanted to share with you kind of some of the key points that I think are worthwhile and taking back home. So I will go to the next slide if this will let me. There we go. So as you can see, the drug of interest is Leqembi. It was actually approved by the FDA for wider use in January of last year, excuse me. And then eventually in July of 2023, CMS decided to reimburse at least 80% of the cost of this drug if patients met the appropriate criteria for early stage Alzheimer's disease. So, between the approval by FDA and also CMS's decision to reimburse this for Medicare patients, we are going to see a sea change in as I mentioned before, in the way we approach Alzheimer's disease and related disorders. So to really understand this drug, I think we have to kind of zoom in a little bit and look at the molecular pathophysiology associated with Alzheimer's disease. And, we all probably know that this is a condition that's characterized by plaques and tangles, but, to really understand how to start a therapeutic agent, you need to understand how everything starts and what's the beginning of the process. And so there is what is known as the amyloid hypothesis that was developed decades ago. And it states that the process of Alzheimer's begins with a amyloidosis. And this is a process that begins when there is cleavage that is abnormal of this transmembrane protein, amyloid precursor protein. So this is the neuronal cell membrane. This is the transmembrane protein. And there's an enzyme known as gamma secretase that cleaves this and leads to these pathological moieties known as A beta. And A beta can form as monomers, and then eventually it forms an oligomer. And then these oligomers continue to aggregate with one another such that you form protofibrils and the plaques that we see post-mortem on imaging and also on the autopsy assessment. So you first have the development of the amyloidosis, and then this triggers a secondary process known as tau phosphorylation. Tau is a protein that's normally found within neurons. It is responsible for the cytoskeleton, and through the process of amyloidosis, there is phosphorylation of this tau that is found normally within the neuron, and then it misfolds and has a different conformation that leads to the formation of tau aggregates. And these tau aggregates form helical filaments, and eventually they become the neurofibrillary tangles. So when you look at a brain of an Alzheimer's patient, this is what's going on a microscopic level in terms of the plaques and the tangles. And you might ask, well, why are these plaques and tangles bad? Well, it also results in an inflammatory reaction and oxidative stress, cytokines, and there's disruption of large-scale brain networks, neuronal cell death. And so there's a theory that if you can block this process, maybe upstream, you may be able to avoid the tangles as well as the neuronal injury. And that's where a drug like lecanemab comes into play. Now, this is a brain of a patient with Alzheimer's disease. If we look on this is the right side neuropathologically, and this is the left side, you see global atrophy involving the cortex and also hippocampal atrophy. And usually the limbic system is ground zero for Alzheimer's disease. And this is evidence for that neuronal degeneration that we see downstream from amyloidosis. And on the right-hand side, these very circular aggregates of protein, these are amyloid plaques, and these are found outside of cells. And then if we look at the bottom right area, we see also evidence for these intracellular inclusions, the neurofibrillary tangles. So plaques and tangles, this is what is seen post-mortem. Now, some of this research has come out of the work that has been done in patients who carry autosomal dominant Alzheimer's mutations, meaning that these individuals, you can test them for a mutation and they may not have any cognitive symptoms at the time, but that they're destined, if they carry the mutation, to develop Alzheimer's disease. And it is a really tragic situation, but also a unique research opportunity that has been seized upon by various individuals. There's Eric Ryman in Arizona, and also there's what's known as the Diane trial through Washington University in St. Louis. And each of these sites have looked at patients who are curing autosomal dominant mutations, followed them over time, checked biomarkers, and then found out the point when they eventually develop symptoms. And there's a lot going on before someone is symptomatic enough to actually walking to the doctor's office, which is denoted here in the green section. So on the x-axis, we have time. Y-axis, we have the biomarker abnormalities. And there's various tests where we can look at the building blocks for those plaques and tangles, whether it be a spinal fluid evaluation or a type of PET scan where we give a amyloid-specific ligand that binds and you can image it. And so this is kind of, again, in vivo, we can see that there's an amyloid process going on, and then downstream, you can find changes in tau in the spinal fluid and also on tau imaging. And then eventually you get the MRI and PET scan abnormalities where there's clearly neurodegeneration in the brain. So it's kind of the plaques, the tangles, neurodegeneration, and then eventually someone comes in with symptoms of cognitive impairment. And so you can see there's quite a bit of a window. We estimate about 15 to 20 years where there's these pathological entities in the absence of symptoms, and that's a ripe opportunity to potentially treat. So the Alzheimer's Association and the National Institute of Aging has developed a 6-stage system of looking at Alzheimer's disease, and there's so many different stages associated with Alzheimer's disease, and this really is integrating the biology of the disease. And so as a neurologist, this is what is closest to home for me. So it's a 6-stage classification system, and we have the preclinical Alzheimer's disease, which is stage 1 and 2, representative of that period before the patients reach that green or symptomatic phase. And then we have stage 3, which pertains to mild cognitive impairment that is thought to be biologically due to Alzheimer's disease. And then as soon as patients start to have impairment in instrumental activities of daily living, meaning that they can't drive, cook, grocery shop, then we say it's mild Alzheimer's disease. As patients get more advanced, they will move from stage 4 to stage 5. And then in the severe stages where patients are fully dependent on ADLs and are having problems with failure to thrive, that's stage 6. When we talk about Leqembi, we are focusing it on stage 3 and 4, which as a group is referred to as early stage Alzheimer's disease. That's the umbrella term that we use. And so, there are a variety of monoclonal antibodies that have been designed within the laboratory setting that have been very provocative in terms of some of the results. Aducanumab, you may have heard about in 2021, where there were 2 different trials that contradicted one of each other. And then we're going to talk about Leqembi today. And then there's another drug called donanemab. And, all of these drugs will bind different species of amyloid along the pathway. So to give you an idea, Leqembi will stick to the monomers, oligomers, and also the protofibrils. Actually, the affinity for protofibrils is very much greater than any of these other molecules, whereas a drug like donanemab will go after the plaques. And the interesting findings are that all these drugs are effective in their own way. So what is going on in the brains of a patient once you infuse them with a drug like Leqembi? And so, our patient who we dosed on December 1st showed up in the infusion center at API, and then we gave them or APA, excuse me, that we gave them the infusion, and we have this targeted monoclonal antibody that has been given at a dose high enough to cross the blood-brain barrier. And then when the protofibrils and the monomers, et cetera, of the amyloid species are targeted, this then elicits an inflammatory reaction that involves macrophages and the other parts of the immune system. There's an inflammatory response, and then this amyloid is removed in some shape or form. And you'll hear later how that inflammatory response, while it is effective, it also can lead to certain side effects that are very much important to look out for with regards to this medication. Now, a lot of what I'm going to talk about comes from the Clarity AD trial. This was from the New England Journal of Medicine paper that was published in I believe it was 2022, early 2023. I certainly would encourage you to track this down and look at this because what I'm giving you is a very brief overview. So this trial looked at a large number of patients followed over 18 months, looked at a demographic that included both early and late stage Alzheimer's, early onset and late onset Alzheimer's disease, age 50 to 90, and then also used various scores as a cutoff of who would be appropriate. So the CDR, or clinical dementia rating score, has to do with a combined measure of cognition and function, usually is the major outcome measure in looking at clinical trials in Alzheimer's disease. The mini mental status score had to be above or equal to 22. And then these patients were randomized based on whether or not they were E4 carriers or they were using Alzheimer's medications, whether it was MCI or mild dementia. And then they received every 2 weeks a 10 milligram per kilogram dose of Leqembi. And I should say that this is a much higher dose than that was previously looked at in similar drugs of the same mechanism of action. And then the primary endpoint was the CDR sum of boxes. And then there were some secondary outcomes that were centered around, kind of generalized cognitive outcome scores, functional scores, the amyloid PET scan, and there were also exploratory analyses that looked at caregiver burden, quality of life. So this slide here kind of shows what really got the field quite excited. So I'm going to first show you the impact on amyloid burden. And, I should say that the amyloid hypothesis is controversial. A lot of people do not believe that the amyloid directly impacts cognition, and maybe it's an incidental finding. But in this figure here, you can see visits between 0 and 18 months and the amount of amyloidosis as measured in centiloids. And the centiloid is a universal unit of the positivity of amyloidosis, and it's seen as these red, orange, yellow areas. And as we go farther into the study, there's significant lowering by about 59 centiloid on average, such that the images are essentially normal. This is non-specific binding of the tracer, so you get significant amyloid clearance. Now the big question is there any favorable impact from a clinical standpoint? And again, we're using the CDR sum of boxes as an outcome score. So in this figure, we can see that there is the visit between 0 and 18 months, the mean change in baseline on the CDR, and you can see that the slope of lecanemab in orange is much less acute compared to the placebo. The slope is much blunter. And so this translates to a 27% slowing in those patients receiving lecanemab compared to placebo. If you wanted to translate that into something that may be more meaningful to a patient, you can say 4 to 5 months slowing over an 18-month period. So I just want to emphasize that what is happening in the brain, we're converting these positive scans where we see orange, yellow, as measured by the binding of the amyloid-specific ligand, usually Flu-beta pair, and then these patients receive the drug, and on average, these patients have clearance such that that it's essentially a negative scan. There's some other measures that I'm just going to just quickly gloss over in terms of activities of daily living. This is another combined functional measure, and essentially everything from the cognitive scores to the combined scores to the functional scores, we see the separation between Leqembi and placebo at 18 months. So some people may say, well, the sum of boxes, CDR sum of boxes has some subjectivity to it. It's not a perfect outcome measures, but we do see these other measures separating between the study group and the placebo group. So this slide also is a nice summary. You see how many patients receive the drug versus placebo. You see that there's 27% slowing on the CDR sum of boxes, 26% slowing on the ADAS-Cog, which is a pure combined cognitive measure, and then 37% slowing on the ADCS-ADL for MCI, which is a functional measure. And then we see the decline by over 50 centiloids on the PET scan. So all these endpoints were met, which is, again, compared to if you knew the history of Alzheimer's clinical trials, this is extremely thrilling for us because we have seen scores of negative outcomes. The one thing I want to say is that this drug is not a cure-all or a panacea. Patients who receive the drug may not necessarily experience clear benefit. They may have slowing of their decline, but let's say you take an individual who cannot drive because of their cognitive impairment, taking Leqembi may not necessarily restore that function. And so that's something important to explain to patients, as well as balance that with the risk of the drug. So, number one, patients who received Leqembi in the Clarity AD trial, 26% of these individuals had an infusion reaction, which is relatively common in patients receiving any type of infusion, whether it be IVIG or chemotherapy. It's kind of like an allergic response. And our nurses at APA know how to respond. What is really unique to this drug is the central nervous system effects. And there's a phenomenon known as amyloid-related imaging abnormalities, meaning that because of that inflammatory response that I showed you in an earlier slide, you can get cerebral edema, localized swelling, Majority of the time it's asymptomatic, but nevertheless, I mean, I think one should be concerned if they have swelling in the brain. And so that was found in about 12.6% of these patients. And you can see this on the FLAIR sequence as this bright, FLAIR bright region. The other thing is the microhemorrhages. So, you know, through the process of removing the amyloid in the brain, you can have this injury that leads to microhemorrhages. And this shows up on a specific sequence known as SWI or GRE, and it's these little dots here. And these are findings that may make someone more predisposed to having a bleed. And so that's something to bear in mind. One way to gauge the risk for these side effects is to look at the patient's genetics. So there's a genetic risk factor known as ApoE4, and this is you know, the more you can have up to 2 copies of this, and those individuals who have 2 copies of E4 have close to 30% risk of these side effects as compared to about 10% if they have only 1 copy. And this also will occur in the first 3 or 4 months. So once you're past 3 months or so, you're kind of out of the woods. So what we have to do is benefit the risk with the benefit. Choose the right patient. And what we're doing at UW is trying to find the patients who are most appropriate, trying to make sure that they have early stage Alzheimer's disease, making sure they have biomarker evidence, and that can be done with spinal fluid taps for those biomarkers or an amyloid PET, making sure that their mental status is within range as measured in the clinical trial. And then if someone on their baseline MRI has any findings of microhemorrhages or large stroke, we will not proceed with treatment. Also, there is some data that there were patients who were on blood thinners while taking this drug ended up with a macrohemorrhage. And so we're avoiding giving Leqembi in patients who are on anticoagulation. So this slide just emphasizes some of the checks and balances. We at UW Memory and Brain Wellness Center do spinal taps to look for biomarkers. We don't have a infrastructure yet for amyloid PET imaging. And we're also checking for bleeding disorders and running tests on the ApoE4. This slide just shows that there's a grading system for the severity of the radiographic findings. So generally, if there's only mild changes with regard to the ARIA, we continue to treat. If it's more moderate to severe, or if there's symptoms, that would be grounds for holding the drug. So that's another way to enforce safety. So hopefully, you know, what I've shared with you, you know, there are certainly some positive aspects from the data, but I also understand that, you know, there should be some hesitancy and caution in proceeding to embrace this drug. And so, you know, in my experience, people either fall on one side of the spectrum. And, you know, this is a very provocative topic. I could talk an hour about this. And so I've left my email, you know, in this final slide. So maybe I have time for one question, and then I probably have to run to clinic.
Thanks so much for that great overview. Does someone have a question for Dr. Rosenbloom? I guess a big question would be if someone wanted to explore this with their patient and weren't at UW, what would you recommend to them?
Yeah, so this drug is approved at UW for use only within the Memory and Brain Wellness Center. So right now, our group is the only one that has ownership of, you know, clearing patients and administering this drug and following patients over time. So, you know, I think, you know, a lot of the things I mentioned in this work in this presentation that has to do with, you know, the appropriate patient. If they're severe dementia, probably it's not worth even bringing this up. But if they have maybe an early stage of Alzheimer's disease, then it may be appropriate sending them our way. And obviously, if they have significantly large strokes in the brain, or if they are on a blood thinner, that would automatically disqualify them. So I would say just think about some of the inclusion and exclusion criteria, and if they are a possible candidate, we'd be happy to see them in our clinic, and you can refer them to us.
Great. And I know you have to go. If you happen to know what you do after the 18 months.
Well, that's another topic we can speak for an hour on. So there's no guidance what to do after 18 months. And I really do not want to treat patients who, have this disease at 65 for the rest of their life with an infusion that is given every 2 weeks. I don't think they want to get that treatment either. The Trailblazer trial, another trial that looked at that drug donanemab, used a different approach where it was more of an induction therapy. So they did an amyloid PET scan at baseline, and then another one, at 6 and 12 months. And they evaluated to see if there was amyloid clearance in the brain. And if there was, they stopped the drug treatment. And once that was stopped, they looked at outcomes, and guess what? Even when you stop the drug, as long as you see amyloid clearance, you still get the favorable outcomes in terms of cognitive slowing of cognitive and functional decline. So I could see a future where we're maybe doing an amyloid PET scan at baseline and after 18 months, and then deciding, maybe we take an induction therapy approach. We have not really, come up with any guidelines for this at this time. You should know also there's an open label extension for all those patients in Clarity AD. And so over time, Eisai, the sponsor of the drug, will probably share that data, and that'll also inform our medical decision making. But right now, yes, it's a big black box.
Great. Well, I know you have to run to see patients. Thanks for providing your contact information, and then we'll share resources, papers, things that Memory Brain Wellness Clinic has been putting out about this medication for everyone. So thank you so much for taking time out of your busy clinic schedule to teach us about something new that we should all know a little bit about.
My pleasure. Thanks for the invitation.
Thanks.
Take care.
All right.